I like to have people in a very low beach chair position, and in fact, I use a regular table, and we have it flipped around where basically the foot is now the head of the bed. That allows the break of the bed to be below the support pedestal, and it gets the patients lower. And for me, not being very tall, this works out very well, and it puts the patient where I like. I always use a rolled up towel placed along the medial border of the scapula, because what we want for an anatomic or a reverse shoulder replacement is to have the scapula protracted. We want to be able to have that scapula come forward into the wound so we can get our en-face view of the glenoid. I also like a support up against the contralateral shoulder. That helps keep the patient in position when we're reaming and putting pressure against the glenoid during the case. And if you want, you can add just a little bit of a tilt to the contralateral side as well with the bed. And also, I use a very simple articulated arm holder that we actually drape over, and this is out of the way. You can accomplish the same thing with a Mayo stand, and that way you can bring it in and out. And one of the important things you need to be able to do is bring the arm into full extension, so that way you can actually access the humerus during the case. And then also that will very often allow the humerus to drop out of the way for you when you're trying to access the glenoid. And sometimes the fancier rigid articulated arm holders can actually block the approach. So we're going to just talk a little bit about how we plan this on preview. So this patient has a reverse replacement on her other side, also her shoulder innovations, and she's very happy. We're going to plan actually for reverse on this side, and her native retroversion is about 13 degrees. We're going to compensate for that. I don't think that we have to overcorrect her or necessarily correct her back to neutral. I've selected only a 10-degree correction with our 10-millimeter post. That's going to lateralize the implant as well as correct for our version. We can see how we've achieved pretty good correction. Now we can add in our sphere. I actually like the sphere to get almost collinear with the lateral aspect of the acromion. And while she has osteoarthritis on this shoulder, she has a lot of significant medialized wear. So I think going with the reverse actually helps work against the rotator cuff deficiency that she's going to have from this prolonged period of wear. And again, we can make adjustments in terms of our rotation and inclination. And again, we're doing a sphere, which is a 33+6, which is in fact what she has on her contralateral side. We can plan where our center screw is going to be, and we want just a little bit of penetration on the far cortex to get a compression. But you'll find when you implant this base plate, it's incredibly stable on its own. So we're making a delta pectoral approach, and I think one of the things that you have to be careful of is that you don't get too far lateral with your delta pectoral approach. With our Mayo scissors here, following the path of the biceps into the joint. And now we can just simply excise it. Give us a chance to evaluate the superior cuff, which has some mucinous degeneration. It does feel a little thin, but otherwise it's intact. And I'm just peeling off the bursa now from the subscap. And now we're going to place a traction suture. And I actually use a heavy-duty non-absorbable suture here. And we're going to lock these sutures and actually leave them to serve as a ripstop suture at the end of the case. Okay. But I think in her case, she has a robust subscapularis as well as lesser tuberosity, and it lends itself to a LTO. So we're going to place the osteotome adjacent to the bicipital groove with the curve such that it exits anteromedially, and this will give us a nice little wafer LTO. But we're essentially creating a Hagel lesion here, taking the capsule off of the humerus distally. Now we're going to take our scissors to run along the top of the subscapularis to define that upper border of the subscapularis tendon. just underneath the coracoid process. Come out, Spencer. And now this is my stitch in time step where we are actually going to distend the joint with a lamina spreader. And we're going to begin some capsular releases here. And this will actually help expose the humerus when it comes time to dislocate it. It will make it easier. This also allows us to see the anterior aspect of the glenoid rim. And this is going to go onto the anterior rim of the glenoid. And now what we'll be able to do is start releasing some of the capsule and labrum. So I'll start anteriorly, and we're going to peel off the capsule if there's any attachment of the middle glenohumeral ligament to the subscapularis. We resect that. And here we're just hugging right along the rim of the glenoid, and I'm peeling up capsule and labrum. We're working inferiorly here, and then we're going to come across laterally, and we can peel this capsule off then of the subscapularis. Now I'm going to take my bovie and work right along the junction between the glenoid and labrum and posterior capsule. We can make it easier to dislocate the humerus, and that is a critical point in gaining our glenoid exposure as well as identifying really the anatomic landmarks of the humerus. You can see that's a very worn arthritic head. I'll take our Lambot osteotome, and now I like to do anatomic head cuts, so we're going to identify the anatomic neck, and to do so we need to remove the osteophytes from around the humerus, all of the alignment of the humeral head, and that will allow us to make an anatomic head cut. We're following the anatomic neck, and we should see the saw blade exit at the footprint of the infraspinatus. So we're just going to take the Lambot osteotome and resect those. And now we'll take our humeral cut protector. All right, now we're going to go expose the glenoid here. So there's a little bit of a tether up top, which is some of the rotator interval structure. And now we're going to peel off any remaining labrum. So some of this labrum is actually calcified back there. We planned it such that we would correct the patient's version. We're doing our maximum correction just at about the 9 o'clock position. So I'm just marking our 3 o'clock. So now we'll do our reaming, and again with our angled reamers we're going to line the correction up. And what's nice about these reamers is they're just about dummy proof. You can't over ream. And now we're doing our center boss reamer. We're going to place our correction to accommodate for the retroversion. So that's solid fixation, and it's not moving. So we have a good press fit with the implant, and now we'll secure that with our central screw, which we measured as 20, and 20 it is. Obviously very secure bite. Let's take our pivot widget now, and we'll do our peripheral locking screws. So we're going to shoot one up right around the base of the coracoid. No, we'll do a 25, and then we'll do 2 more around the scapular pillar. About a 25 again, and 20 for that last one. 25 off. So typically we put these under power just until the threads engaged shy of the locking mechanism, and then we'll put them in final tightening by hand. And we have a little bit of conflict at the bottom, which we're clearing. Kind of this inferior osteophyte. We position the sphere in the center of the joint. And we get good lateralization, but I think it's also worthwhile to maybe trim away a little bit of this osteophyte at the bottom of the rim of the glenoid, and that way you don't really worry about any conflict. And making some pilot holes is a good way to make sure you don't propagate any fracture. All right, so we have our 36 plus 6 lateralized sphere, and we're going to use it to slide in there. We've got good engagement. We'll give it a couple of taps, make sure that's Morse tapers engaged, and then we will set our final engagement. All right, so we know we're down, we're clear all the way around. Looks good. I've gone away from trialing, and basically what I want to see is that cut surface or our cut protector. If it glides across the sphere, I'm happy with that tension. And at this point, I asked the team to provide me with a 0 stem, because I've been using 0 stems in everybody, a 0 tray with a 0 poly, and that gives me the tension that I'm trying to achieve with our final construct. We can utilize the 38 millimeter head as a template for our guide pin, because we know that this is the same diameter as our tray. So I'm positioning this in the center of the cut surface, and that centers our tray. And now we're going to base the humeral preparation off of that. And so we line this up with the cut surface, and there is a curve to the stem. So as I am impacting this, I am raising up my hand. And now we have that flush. And if you want to, theoretically, you can impact that a little farther and get even a more inlay. And now our bowl reamer slides down over the implant, over our broach. I'm just going to go ahead and place our sutures for our subscap repair. And we will also place an additional rotator interval suture. One of the tricks we can do to help with suture passage and drill passage is we use the bovie, and it makes for quick work. So again, we're passing pairs of sutures. And this will go around our lesser tuberosity osteotomy. And we will pass an additional number 5 braided suture for our rotator interval. So we have the assembled construct here, and we'll drop it in. Okay, so the implant is down, resting up against the cut surface. And then the reduction maneuver should be a relatively easy lateral push as we internally rotate. And now we have a nice stable construct. And we're passing looped sutures because we will tie these in a rack and hitch or niece knot fashion. Is that we can provisionally tension our repair without the sutures backing out or losing their forward tension. And we can make sure we place this as close to anatomically as possible. Little external on the arm, and it takes 3 to 4 alternating half hitches to secure the rack and hitch or niece knot. Cut piece there, okay, and now we'll just do a bit of a varied figure of 8 across the apex of the rotator interval there. Cut, please. All right, so we've got a shoulder that moves like it should.